Oh, good morning.
Good morning.
God, I didn't even watch this. You know me and music. I'm sorry. Good morning.
Good morning.
How are you?
All right, and yourself?
I am well. I am well. You sound okay. Okay. That's where I hear that all the time. See, I blame my husband. It is you and him. That must be a man thing. Because every time I'll be like, well, how are you? All right, and yourself or good in you or something he says is just like that. And I'll be like, is that something that's just ingrained and you just say that it just comes out when somebody says whatever? He was like, yep. I was
Yeah.
like, okay. And I blamed him. But I get it from both of y'all. How's it going? How's your week?
It went by pretty fast.
It did.
I
It
was like, I mean, I wasn't complaining, but
No, not at all. Not at all.
but it did
Not
go
at
by pretty
all.
fast.
It did, it did. And the weather, we have schizophrenic weather over here in Ohio. So one day it was almost 70. The next day it was barely 40. It was like, really? This what we doing? But hey,
I like the green nails.
thank you. I went to the store and I use OPI products. No, they're not a sponsor. And and I just saw it and I said, that looked different. And then I saw somebody um that had some green nails last weekend and I was like, well, green, that's different. Let's see. So here we go.
Do you get gel or just that's just regular polish?
It's regular polish. I
Okay.
do the one, so they got listen to us. They got different formulations, and I haven't tried the natural, but I'm leaning to that. But I need to make sure when I read the information, it doesn't last as long. Uh, so I get the one in the silver cap that has like the gel like
Mm.
covering over the top, and it does last almost 2 weeks.
Okay.
And it's not hard to get off. That was the other thing. Like I tried to do some gels before because like
Your
I'll
gel
grow
is
my
hard to get off.
I was like, I'm about to break all my nails just trying to get scrub this mess off. No, we're not
But
doing
you
that.
have to
So,
soak them though with the gel. You got to soak.
see, look, I should have called my friend because I know you know. Like, what don't you know? Good morning, Tasha. Good morning. Good morning, our on the street correspondent, the crafty
Yes.
coder. Good morning. Good morning. Okay, well, let's get started here because let's just get started. So, welcome everybody to the Saturday morning tea where we discuss health information, news, education, certification tips, entrepreneurship, the revenue cycle, just all things health information at large, just all of the things. And as you come in, don't forget to hit the thumbs up or like button. Good morning, Vicky. Good morning. Wait, let me. Good morning. Good morning. Oh, I didn't see her either. Good morning, Tanika. Hey, hey, hey. She said she shouts out to the KC. I love it. I love it. Okay. Look at the family. See, we are all family here. Look, see, I love it. I love it. Okay. Anyway, um, so as you come in, don't forget to hit the thumbs up or like button. You know we need engagement. So that's one thing you can do. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Hmm. Well, if you don't, before I introduce my co host, let me share with you information on a free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right, all right, all right. Go get it. You could do it. Uh oh. See, I'll be putting a verse over that tight beat real quick. So, again, if you're interested in getting more information about the 5 steps to become a certified marketable medical coder, check out the video description for the link. Joining me today is my co host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in healthcare for a mighty long time. And in 2014, I transitioned into the world of HIM. Then in 2020, during the pandemic, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Not a mighty long time. See, you didn't. You done stirred up the old school. A mighty long
Yes.
time. All right, all right. All right, Miss Crafty Coder. If you don't know, you are in the right place to find out how to become marketable. Exactly. Absolutely. Because we spill the tea over here.
And before we go, speaking of marketable,
Mm-hmm.
I last week, well, actually, I had been taking this data analytics course through AHIMA,
Mm-hmm.
and can I tell you that assessment turned me every way but loose, but I got it done.
Yes.
I had to do 2 takes
Oh,
because the
okay.
first one I missed it by 2 questions.
Okay.
Then
Okay.
on the retest, I got them all right. I was
But
like,
you really enjoyed that. I remember you talking
uh,
about how much how valuable and informative it is, and bless Ahima's heart. I really feel like I think there's the tide is shifting. I will say that. I feel like they are listening. That's a whole other conversation. But just since you were here, I feel like they're listening to their members a little more, being a little receptive, and they're revamping all kinds of stuff. When I tell you, the book of knowledge is a different book. They're going in and shaking up. So I think they really have been listening. Everybody got your congratulations,
oh,
congratulations,
thank you.
congratulations, congratulations.
Because to me, like in my opinion, I really believe that AHIMA's book of knowledge should be similar to the coding clinic. Like you should not have to
Mhm.
pay for a subscription to the coding clinic to get information if you're a member of AHIMA. They should be able to have that same information.
Right. And I remember, oh, what is it? I forgot what it's. I think it's called the Compliance Suite. It was with Walters Kluwer, and as a compliance, professionals, it was like our book of knowledge. It was our Bible, and so you can easily go out there and reference all types of citations, all types of um, manuals, all the things. And once upon a time, coding clinic was part of it. I want to say both the coding clinic and the AMA or the CPT assistant were part of it. And then one year we lost the CPT assistant, and then 1 year we lost the coding clinic. And I was like, for real? Like you pay all this money, and don't get me wrong, it was a very very valuable tool and worth every cent, but it would have been a little more valuable, especially for those of us who are multi credentialed, to have those additional components added to it as well. But you're right. I feel like uh, we use these codes. This should be a tool that they collaborate or partner with them to offer that information to us, and maybe they don't give it to us the day it comes out to the public, or the day maybe we have to wait 30 days. I don't know, but it should be available. It should be made available for us to have it. I agree with you on that. Maybe we need to send in a comment. Maybe I need to call our Kevin, our CEO, and let him know, since he like to give out his number.
And I also I told you like, I feel the same way about them, limiting the access to the 3M encoder. Now you have to be before anybody could, if you
Anybody
were a
do it.
member, anybody could
Mm-hmm.
buy it. And you get access for a year for $75. But now you have to be in an approved program. And I think that what they should do is, if anything, they should maybe charge people more if you're not in a program, but they should still be able to access it.
I'm having a thought. At our OHEMA annual meeting and the convention and the vendors, I think I ran into somebody who is with three. They're changing their name. 3M is doing something. They're either morphing with another company, or there's a name change about to happen.
I think they are, because 3M is really trying to compete with Epic. That's their end goal.
You're so silly.
Yes, that comment, a limb or two.
A limb or two to pay for it, ma'am. Is absolutely correct. You know what? Maybe as we think about the collective, maybe that's something that we could have at our disposal for our Patreon folks. Let's think about that. We may think about that. Okay, that was good. That was good. Yeah, but when I saw that, because we were talking and she was like, "Well, are you?" And I said, "No." But I work with several organizations that use the encoder, da 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 da. And she was like, "Yeah," because she wasn't from our region. The person who normally holds the contract for our region wasn't there, and so she was telling me, and so it's a transition for them, because the staff now has to sign up with this other company. You know how that works. So I think her mind was on that because it was fresh and new. And then they had the new name, because I was like, well, who are you? Because I went around to every booth to thank them for being vendors for our show, and so that's why I was like, well, who are you? And she was like, we're really 3M.
It isn't the new name like Solventum or something like that?
Something, yes. And they have green. Green is in their colors. So
Okay.
green was in their colors, because we were talking about that. She was like, see, we did this right on time for St. Patrick's Day, because that's when we did our thing that weekend. Yes, yes. So look at us spilling tea before we even get to the tea. How about that?
Mm.
Like, all right. So some of you already know, because y'all already in here. Oh no, I hate that name. Here we go. Here's, as you already know. Let me remind you that you can join in and add to the conversation. Our chat is already buzzing, so feel free to add your comments or questions in the chat. And don't be shy. Your opinion matters and it's welcome here. If you have a question, just put the Q first so we know it's actual question and we don't miss it, even though we try to hit everybody and post everything. But I feel like we're gonna have some additional tea coming down the down the trail. So for those of you who are just joining us today, we are talking a little bit about, or if you're watching the replay, you could be a replay watcher, which is all well and good and fine. Today, we are looking at training plans, skill-based hiring, and AAP truths. But before we get to that, let's look at our church announcements, shall we? All right, so my church announcement pretty much for today is it's March 30th, and it is Happy National Doctors Day.
Oh, this is a perfect weekend to talk about compassion and sacrifice.
Compassion and sacrifice. That should have been their theme. That really should have been their theme. But their theme this year is wings and stethoscopes, healers of hope.
Oh, okay.
That's their thing. So I said, well, look
So
here.
AI generated that title, but go ahead.
So for those of us who use AI, we can spot it a mile away. I said, if I see Dell in anything, I get mad every time. Like they spit. I do not use Dell. I don't talk like that. Stop. And then I'll see it in something, and I'll be like, okay, all right. But wings and stethoscopes, but they are healers of hope. And happy National Doctors Day. I'll save it for another week. How about that? How about that? There. I was looking for my little usher finger. She said wings and stethoscopes. Yes. But they do a lot. I think, especially our young, fresh, green, bright-eyed, and bushy-tailed doctors are really, I think the intention when they first go in is a good intent. I think somewhere along the way, sometimes some of them, a small group, may turn left when they should have went right. Maybe they may hit that crossroads, and they may shift in that crossroads. But for the most part, I think their heart is right. I think if you thought you're going to be compensated or paid or live kind of the life that some of your fathers, grandfathers, and great-grandfathers live, I think that's gone. I don't think that is here. So you really, really have to be intentional and really, really have to be about care for people, I think. But I do appreciate that you are all here. I appreciate all you've done to care for the masses. I know this is a national day, but doctors across the world, even those who are in the U.S. and who may travel to other countries and help and do all the things and the research and all of that. So happy Doctors Day to you. Mr. Jesse, did you want to add anything about compassionate sacrifice?
I mean, we clearly need doctors. We truly do. We wouldn't have healthcare without them. So
look at y'all. See, I feel like we done jaded. I'm going to keep it nice and not say anything.
So, I mean, all I can say is, look, thank you for your service.
I feel like Veterans Day.
What? Well, not to throw a wet rag into this, but did you hear the article about the doctor in Texas that was tampering with IV bags? He was a surgeon. He was putting in nerve medicine and other causing people to develop complications, not during his surgeries, but during other people's surgeries. And
how did he get into the bags? He injecting stuff in there?
Yes.
On a sneak? Like how?
Yep.
That's a nose job. I mean,
And they caught him on surveillance.
Oh my God.
And this started because they said that he had found out 2 days prior to this that he was being under investigation, but they didn't say for what. And what happened was a doctor, I'm like, wow. So a fellow physician had taken a bag home, to infuse herself with saline to give her, some energy, and she died.
So he didn't pre-poke these bags or whatever.
Yeah.
Oh my God.
But not for his surgeries, for other people.
So it wouldn't come back on him? So Dr. Death, for real? This is what we want to do? So was the intent to harm?
Yeah, well, yes, injecting that medicine because he knew the effects. It was two different types of medicine, and people were having cardiac arrest. And
did he wear Dahmer glasses? Let me stop.
Oh.
Anytime I see, I be like, them Dahmer glasses. We got a problem on our hands. Y'all need to follow and check them. Okay, I'm sorry. She said there's a whole Chicago Med episode right there. Grey's Anatomy. Oh my God. No, I didn't see that.
It was on TikTok.
Okay.
Well, of course.
Yeah. Of course. Of course. Okay, and then my last announcement is for those of us in health information, remember HIP Week. So for health information professionals, our week is April 15th through the 19th. And the video that I was supposed to record this week, that I'll record probably today or tomorrow, will drop next week, and it will give you some insights into HIP Week and some things that you can do to celebrate, both if you are in person or a virtual team. So check that out for next week.
Well, before we leave the church announcements, I want to know how many churches are going to get the Trump Bible.
I don't know. Is that gonna be I wonder if that's gonna come up on my U version on my phone. You know, you get all the different versions. Is there a different version? This Trumpalicious?
I don't know.
Chapter 1, verse 3. I don't know.
Could you imagine? Like, because I was just wondering. Like, so are they gonna have, like, in addition to, we always talk about the King James version, there's gonna be like a Donald Trump version?
That's what I'm saying. That's
crazy.
The Trump International version or something. I don't know.
Exactly.
I don't know. I wonder if they're gonna even bring that up on this holy weekend of services. I don't know. Bless everybody's heart.
Yes.
That's all we can do is bless everybody's heart. All right. Okay, so let's see where I want to go. All right, so I got all that. So I can't even say this because we already here. I'm about to say let the tea spilling begin, but I swear I already see a puddle right here on the floor. On the floor. So first, I want to talk about this woman on LinkedIn, and so I don't know if you know that the video is no longer available. I forgot to add.
Oh no!
I know I forgot to do something. So I'm sorry, y'all. If you look in the comment or in the description box, I forgot to add these links. I'll add them when we're done today, so you can go back and pull the links if you want to see stuff. My bad. I'm sorry. I was doing too many things. I was trying to get ready for church yesterday. But anyway, this week, Tiffany Robinson posted on LinkedIn a YouTube video that she did about the AAPC. And she threw a little shade too at Ahima, and a couple things that she said I really wanted to correct, because some of her things wasn't right. I too have been a president of the AAPC's local chapter. I've been a vice president. I've been an education director, and my favorite role was membership development. So I've served many years at my local chapter, until it was like, can somebody please step up, because I got other things I want to do. But so she talks about that, and she mentions that she has served in several of those roles. So what had happened was, she talks about the AAPC virtual events such as DocuCon, HealthCon, AuditCon, all the they the cons of the, you know what I mean.
Yes.
But she said the problem that they had was with their credentials, and not giving folks the appropriate CEUs for the credentials that they have if they spent the money to go to these particular conference that goes to some of these conferences. So she was in her feelings, and rightfully so, and most folks do. If when they either turn to social media or contact the group, and I think she actually did both. But she wanted to help. She had a whole buyer beware warning to warn people about their business practices and how it was hurting those members and chapter officers and all of the things. So I went back because I wanted to. I watched the video and I shared the video with Mr. Jesse, and I wanted to go back, and I was like, "Well, where is the video?" She took the video down, and she had an update that she got off the phone with someone from the CEU department of AAPC. And so she will be credited for her classes at DocuCon. So what happened was she is a CDEO, which is the AAPC's kind of equivalent for clinical documentation specialist, but for on an outpatient side, I believe.
Yeah.
And she went to DocuCon, and it was all about documentation and all the things. But unfortunately, they were not granting the CEUs for, I think, multiple uh, uh, sessions um, for that credential. So one thing that AAPC does is, now that you don't now well I think now that you don't necessarily have to have the CPC credential as your feeder, you can jump in and get any credential, because years ago you had to get your CPC before you can get any specialty credentials, and they blew that up. um, they offer certain educational sessions for certain credentials. Well, the thing is, and I think this may be something that was a problem for someone who filled out the documentation for the CEUs, because there, when you're applying for CEUs for AAPC, you have to specify who the audience is. You have to specify whether or not the information that's being provided is for um, those with the CPC, or is general. So that's, everybody, or those, with CPC, or you can also specify the specialty credentials. And so you have to, and I'm dating myself because this was a piece of paper. I don't know what it is now. It's probably just electronic form, but you have to check all of the stuff for all of the credentials in order for them to come and say, hey, I attended, I want to get my CEUs. And maybe that didn't happen. Maybe that was an error on somebody's part, maybe even at the AAPC. I don't know. But I know that's how they were doing it then. And I don't want to make an assumption because I don't want to make an ass out of me and you. But I'm assuming that even though I just said I am assuming, that still carries today, because you want to specify who can get it. And multi-credentialed AAPC members have to get so many CUs for each type of credential. So it makes you really laser focused on, is this something I want to do, because I need to get more of these types of credentials. Is this an opportunity to do that versus some just general? Because you can get all kinds of stuff for general stuff, but it's oftentimes slim. But I would agree with her on the DocuCon being about documentation. That should have definitely been for that particular credential. And Mr. Jesse, if you want to jump in, feel free at any
But
time.
no, I agree. Go ahead. You're honest. It's spot on.
Oh, and then the other thing she mentioned, but I mean, they rectified it. So, prayerfully, if somebody was in the same boat, where they noticed that their credentials weren't added for their attendance at DocuCon, that they too got. Hopefully, it wasn't just a one and off. Hopefully, everybody who was caught up in this debauchery received that benefit. Um, and then she says, thank you, Alex from AAPC, for reaching out to me personally. AAPC, I'm back in. Really? But anyway, so the thing that she said about Ahima was, her gripe was the location of her, um, I want to say her state association. So here's the thing. AHIMA is a federated model, and AHIMA starts at the national level, and they only um, coordinate with the component associations. And so that's your state. So when you become a member of AHEMA National, a portion of your membership dues go to your state. So you national and you state, you automatically become a member of your state. You also have uh regional, or I forget what they call it. Most of them are regional um uh places, because there's only one state component association. There aren't multiple. So the regionals are pretty much their own standalone that can then jump in and have a contract with the state. So it feeds up that way. So AHEMA is not, they don't have nothing, and they'll quick to tell, trust me, I know the component association, we ain't got nothing to do with your regional people. That's y'all. We only deal with state. You state can deal with the regional as you see fit. And um just this year, it actually benefits those regionals to coordinate with the states because of some of the things that are happening as it relates to education and providing the education that they or getting CEUs for the education that they provide. It's a whole thing going on behind the scenes. More to come on that later. However, I just wanted to let her know AAPC National don't play in the same playground with your regional people, and so I think she misunderstood that. Um, as she talked about, well, it was so far away from her. Ma'am,
Right.
you can start your own regional where you are. If you got enough people to build that up, you can start that, and then contact and connect with your state to be part of that association, so it'll be a feeder. But somebody in your area or region or whatever has to take the initiative to do that. That's not the nationals problem.
Right.
This one right here is on one today. So
Mhm.
AAPC Allen showed up and poof, the problem is gone. Ah,
But I
oh,
would love to know if they asked her to take the video down or she took it down after her problem went away.
sir. I mean, because that video was like, go. I said, well, is something wrong? Look, I done went to a whole different computer. Like, well, maybe it's
Right,
just my
because I
phone.
watched it. You know, when you
We
soon as you
watched
sent it,
it.
uh-huh.
She had some little views. I feel like y'all gonna compensate me for that. Well, maybe something gonna happen. I don't know. But she has some views. She got some followers. She has a following. Um.
She does, yeah.
Mhm. But yeah. But I thought that was interesting. Interesting that uh all went away real quick once she got it.
Mhm.
So good thing that they came out, especially with all the conversation and all the stuff that's happening over there. Lord,
All I can say is it's amazing what CEUs can do.
ain't it? Ain't it? Oh my god.
Look, like Nina Turner says from your great state of Ohio. Hello, somebody.
Hello. Ah, oh my god.
That's all I'm gonna say.
All right, all right. Okay, so moving on. um, so um Paula Achilles, I hope I'm saying her name right. Wrote, she's a program coordinator and assistant professor at a college, wrote an article on your coding career getting to where you know to go. And I thought this was the cutest little article, particularly around um, putting together a training plan. So, we often ask people when they come up to us, as they often do, what do you do? How can I do that? How can I learn coding? Well, what, ma'am? Slow down. And you try to give them some history, you try to give them some information so they can be an informed consumer, because it's out here in these streets. You can get easily, as we have discussed several times before, um of these programs. And this kind of, I think this happens this training plan that she mentions kind of happens maybe before you get into a program, but I guess it could potentially happen after too. Once you get to see, well, which one do I like better? Am I a fan of ICD 10 and CM and PCS, or am I a fan of CPT? I mean, I guess it depends on where you shake it, and then that can help further develop, your plan on where you want to go. But I'm jumping ahead of myself, I know. But before that, when folks just start talking to us about the profession, and we the first thing we normally ask, well, inpatient, outpatient, provider, professional, like, because it's the difference, and you're going to learn different things in those. You're not going to learn it all. Um, well, now, even if you go to a degree program, they will introduce you to them all, but you're not going to dive into them all in that type of arena unless you pick your niche and then further develop the skills for like inpatient, for example. You develop your skills for PCS, you develop your skills for um, you know mastering chart, actually reading the chart and knowing what documents to go to find what you need in order to um, code accurately for both diagnoses and procedures and that kind of thing. So, the introduction is, this is what we do, this is what we use, da 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 da. May crack a book open every now and again and show and point and whatever, versus let's deep dive. Let's code some cases. Let's learn what this documentation looks like, what this documentation is, how it impacts your code selection, et cetera, et cetera, et cetera. Um, this training plan, however, was uh, something that helps you define what you want to do for real. Like, where do you want to land? And then making sure it reminded me, like, of, I think we talked about this too a couple weeks ago. Your career journal, or just mapping out. Okay, well, if I'm interested, I'm starting out as an inpatient coder. I like ICD-10 CM, and I'm thoroughly impressed and enthralled with PCS. And maybe on the other side of that, I may want to be in clinical documentation. So let's draw the path of how to get there. What do I need to do? What type of skills do I need to learn? What type of movement? Who I need to know? What do I need to gather to make sure that ultimately I can reach my goal of clinical documentation specialist, if that's their goal. So this is really just putting together um, a plan, if you will, on how to get from point A to point B. And so she used an example of transitioning from outpatient to inpatient coding, because again, they're different. So her questions, she had like 5 questions. What area of inpatient coding? Again, you have the different areas, but then you have specialization within inpatient coding. Maybe you like surgery. Maybe that's your jam, and you only want to code surgeries. Or maybe there's specific um um uh a specific specialty like cardiology or neurology or what have you. So again, you can go all the way down to where you are in your happy place and all you see is this, and you're like, yes, this is what I want. Until you see something, you be like, I don't want that. Let me pass it around. But you can get it to where you're where you want to be. She also asked, how will you gauge your success? What resources do you need to take you from here to there? What value will this bring to you and your current or future employer? And when will you get this done? Now, she kind of crafted all of these around SMART. We all heard the SMART goals: specific, measurable, achievable, relevant and time based goals. But I just thought it was something to keep top of mind, particularly as we're some folks are transitioning, because as we know, folks have been, I mean, AI is out here, it's heavy, everybody's looking, everybody's questioning, everybody's concerned, everybody's on the fence. And maybe you are thinking about, or should be thinking about, the transition to from frontline coder to maybe auditor or reviewer or CDI or data analytics or some of the other opportunities that are available to us as health information professionals because of the knowledge, the skills, the stuff that we bring to the table. Maybe this is an opportunity to say, okay, well, let me sit down, maybe answer some of these questions to determine where do I want to go? What do I want to do? And how do I get there? Mr. Jesse, did you have anything you want to add?
What I the only thing I want to say is I really enjoyed her article, but people miss, like, the thing that I have a problem with a lot of these articles is that they have divorced themselves from the real world. Because in the real world, everything she put down, everything she listed, that's nice. But in the real world, it doesn't happen like that. Because people don't eat, like, even just transitioning from outpatient to inpatient. People don't realize how hard it is. Not because of the skill set. All you need to know to transition from outpatient to inpatient is ICD-10 PCS. That's
No.
it. Because you already know ICD-10 CM.
Hopefully.
But, well, I mean, but getting the opportunity is where the problem comes in.
well, the other part of that, because yeah, you may know ICD 10 CM on an outpatient. You're usually, well, it depends on what type of outpatient. Let's start there. Because if you're like outpatient clinic, outpatient infusion center, outpatient, you may have some different documentation. Inpatient, you have a whole bunch of stuff that you potentially need to weed through in order to get. Outpatient or professional, you may be looking at just one progress note or one office note or one whatever. So understanding that piece, because you'd be like, oh, I found it here, boom. And like, no, you got a whole bunch of other documents that may support or reject what you're coding as your diagnosis, because you're only looking at one thing in the totality of it all. But I don't know.
Right. But you still, but
I mean,
whatever
but the
you code,
skill of
right, right.
yeah. I'm with you.
Whatever you code has to have meat. So
Yes,
whether it's inpatient or outpatient.
yes.
But the hard part is getting in, because I will tell, I tell the story all the time. It took me 2 years to get an inpatient CDI position. I tried to get inpatient. I even tried to get inpatient coding positions, which, as it all turns out, I really didn't want to do it. I would not have liked that, because because they have to code every single thing,
That's what I'm
and
saying. That's the
I don't have to, and CDI, I don't have to do all that. Like, when I go to reconcile a case, all those, you know, history of codes, because during the inpatient stay, I don't deal with that. I'm dealing with why are you here, what's going on right now, and that's it. And then when I
mm-hmm,
go to reconcile, and it depends. Sometimes I don't add them because they're not relevant to what I have to do. As long as that DRG,
mm-hmm,
as all that MSDRG and that APR DRG match, I'm good,
mm-hmm,
because that's where the money's going to come from.
mm-hmm.
So it's just a lot harder. It's way harder to get an inpatient position than an outpatient, and it really should not be. And then also, there is nobody like these um, facilities, whether they're inpatient or outpatient, are dropping the ball because they no longer develop new people. Everybody expects you to hit the ground running like you've been coding for 5 years. It's just not possible. And I don't care how you train somebody. You can train somebody for 12 weeks. They still have to adjust to real world coding. You have given them perfect charts. So, of course, anybody can do that. But once they come into the real world and start seeing this, less than stellar documentation and trying to make things fit, They
That's
still,
an art in and of itself.
right. You have to be guided through that.
And the policies and procedures of that particular
Exactly.
organization, because they you would think it was a standardized
But
concept, but it's not.
exactly. And they don't take any of that, like, and that's my problem. Like, they mislead people into thinking, oh, it's just 1, 2, 3, and then you're in. No, no. And I've said it on, on this platform a gazillion times. I am not a fan of new coders working for contractors.
Mhm.
But sadly, that is
That's the
really
only
how
way
a
they
lot
get
of people
in.
get their experience.
Yeah.
And they are traumatized as a result, because when you work for a contractor, it is all about production, because
Yes.
that's how they get paid. And they
Yes.
have promised this vendor that they're going to be able to perform XYZ number of reviews, period. And all they care about are the results. And your 50,000, 12 questions about each chart is not going to help that. And instead of them nurturing people, they just they just abandon them. Because what I think they should do, I big up Inovaline all the time, because they were the ish. Once we went through training, this was before their initial model when I started. They Once you finish training, we could call a helpline with coders. We would read to them the documentation. This was before we could even share screens. We would read to them the scenario. They would apply the policies for the company and for that project and say, well, no, well, based on this, you can code that, or yes, you can code that. That people need support
Hmm.
ongoing until you get to a point. Even now, I've been in this now. All next week will be 10 years. I still need support. I don't know everything. I
You
still have to
don't.
bounce things off of people.
That's
I
why
still
it's
have
a
to learn.
lifelong learning
Exactly.
profession. You
So
don't.
how they feel as though you don't have to do that, especially in the beginning. You need somebody to hold your hand for a good year to get
Or
it down.
more. You're right.
Exactly.
You're right. I agree with you wholeheartedly. And then we also, you said it shouldn't have to be that hard going from outpatient to inpatient. But as we have discussed, the elephant in the room here, the gatekeepers are real.
Yes.
The gatekeepers are real. And historically, and I think it's, if I'm remembering some data that I recently looked at, I think historically the bigger salary coding positions were inpatient, not necessarily outpatient. So, you know, you had to move a little different, know a few different folks in order even to get into that arena, into that space. So, yeah. But I thought it was a good article just to begin to think about what is necessary and what you need to do. Um, Now, implementation and execution is a whole different thing, but at least planning if you are going, um, if you're going in a different direction than where you currently are. Tanika says, "Yep, support is definitely needed in coding. A solid year." Yes, and the crazy part is people magically believe that, oh, I've gone through this coding training, I got my credential, and I'm I'm it. I'm here. I have arrived. No. You don't even know the half. Well, most time you don't even know the half until you get out here in these streets. And these streets run a little different, and they evolve every year.
They sure do. And you have, and this is also where, because I say it all, like, you have to have company policy regarding coding. You
Mhm.
have to, have
Mhm.
to, have to, have to. And the easiest one I think about, especially in outpatient, I think about like uncontrolled diabetes. A lot of doctors will document uncontrolled diabetes. Just because you put the hemoglobin A1C under it, that means nothing to a coder. We can't code based off of that. You have to say whether it's hypo or hyperglycemia. And you
Mhm.
need a policy to say that, okay, well, if it's not documented, you can only code E11.9.
Correct.
And
You
that
need some.
clears it up. And
Yep.
then once they get the data to see how many missed opportunities they have, then that provides an opportunity for that organization to do some provider education.
Mm-hmm. And
That's
show,
how it
because
should
they
work.
like the data. They want to see the
Right.
whatever. Like, okay, well, see, since you're not doing XYZ, here's the revenue that we're missing based on that. Then everybody eyes light up. Well, wait a
That's
minute,
right.
what? Who? What? And then all it takes is them to put this versus that. Oh, well, wait, whoa, whoa, whoa. Hello, ma'am. Hello, sir. I'm gonna need you to go ahead and make sure you documenting those things appropriately.
And what I'm also speaking of Lincoln, and what I have seen it is now providers are starting to link diabetes and hyperlipidemia. So you can code E11.69. And
Mm,
that actually, I had heard about that, but I've hardly ever seen it done. But I'm starting to see it done a lot now.
okay.
Like they'll say, diabetes complicated by, or diabetes, associated with hyperlipidemia. I'm like, oh, okay.
All right.
But you have to also know how to code that. What does
How to
that mean?
code it. How to
Exactly.
code it. So, Miss Vicky says, "Yes, thank you, Jesse. Us students and newbies being able to get into this field is so discouraging and difficult. What can we do?"
Oh, I got that. You have to network like you have never networked before. Because what I am finding out, and especially now, and it is not just coding, it is across the board. Now it is about who you know. Because so many people are looking for opportunities now. So
Mm-hmm.
many people are being laid off now. And I say it all the time, like, like all of these tech people who have been laid off, once they get a whiff, oh, I can just tweak this a little and get into healthcare. It's gonna be over because they have the skill. They just don't have the healthcare knowledge
Right.
to complement that skill at this point. Once they get that, it's game over.
Game over.
Because like I've told you about, the young guy who has helped me learn SQL and Python. You know, I told him, I said, what you do right now is like at least 5-10 years ahead of healthcare. They're not that deep with it. And if you can, you know, learn the healthcare piece and combine that, you could really do some damage and really make some money and make an impact
Right.
because you already know how to do it. Like this will be light work, but you have to make the connection from the data to healthcare. How to make all that work in a healthcare setting with this type of data.
Right.
So I think that it's important to network. I think that especially whether if you want to get an AHEMA credential or an AAPC, you need to be involved in your local chapters.
That's right.
And every time they have a chapter meeting, you want to find out who's who, where they work, and then you want to find out, hit them on the side and say, I'm, really passionate about coding. I'm trying to get in. Does your facility or does your place of employment have any opportunities?
Yeah, I was about to add to your networking, um, because you mentioned it's who you know, and let them get to know you. And so you explain to them, or you tell them where your level of proficiency is. You let them know, hey, I know so and so and so. You throw some words out, because again, they have to be able to. It's so one thing about this industry and this profession, that networking can get you your foot in the door, or that networking can get you a whole seat at the table comfortably. And if they know who you are, what who you are ethically, if they know, you know, your your uh, your work ethic, if they know um, what you're bringing to the table, then they will vouch for you. If they don't know you, it's like, okay, well, whatever, you're so and so. I mean, I don't really know them, but and you may try, but if they know you, so make sure you in that networking relationship, don't let it be a one and done. Hey, can I buy you some coffee? Can we sit down and have some tea? Can we talk about whatever, 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 and make it genuine, and make sure you have something, because it shouldn't be transactional. It should be a genuine, communication. Hey, I'm interested in what it is that you do. I want to kind of get into that same field. So find the people who are in the same type of coding or any type of health information sector that we have, and say, well, wait a minute, well, what exactly is it that you do? And I'm interested in knowing about da 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 da. And how did you transition? And have the conversation so they know. Oh, wait a minute, I know Clarice was talking about so and so and so, and she was looking at this, and maybe she'll be a good fit. Because to your point about those local chapters, they know who hiring for what and when and where before it hits the LinkedIn's
Mhm.
and the what all the different
And,
places that they post the jobs. They know
and
before, and you can hand them, here's my resume, can you take this to so, yeah, well, let's take a look, and then that ball goes rolling. Even though they still have to post and do whatever, they may have somebody's resume in hand that they can say, oh, okay, yeah, we see this is a perfect match, we want to talk to them, let's bring them in, versus going through what they got going on now.
I and that same thing happened. I was able to help one of my students get a job where I work right now. Like,
Mm-hmm.
she had taken both of my classes. She did everything. And actually, she and another student, I've recommended two students. We were in a meeting. My manager said that they were looking for somebody. This was before the position was even posted. And I sent them, referred the two of them to my manager. They both sent their resumes. They picked one over the other. And now she's in. This was before the position was even posted. It was already like a done deal, which
Mm-hmm.
happens a lot of times. Like, and people don't understand, just because a position is posted doesn't mean that they already have somebody a lot of times. They
Mm-hmm.
just have to legally post it.
They have to legally post it.
Like, you're never going to get in because it's already decided.
And
And
I
some, okay.
go ahead, I'm sorry.
And I've even seen on LinkedIn where, I mean, not LinkedIn, Indeed, where they have
Indeed,
said
that's what I was thinking of.
the position has already been, they already have a candidate in mind, but you can apply anyway because legally they have to do it.
Hmm. And I've said this before. I shared this before. My experience and my story. Probably 90% of the positions I've ever held is because somebody knew me and said, "You looking for something? We might have something for you." I'm like, well, let's talk. Let's see what it is that you may have, and if it's something that I may want to do. That has been, and because I believe it or not, I'm an introvert. Another fun Clarice fact. I am very introverted, for real, for real. But I know how to turn it on when I need to. And I'll be like, well, really? Well, who are you? Well, tell me a little bit about da 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 da. And we'll roll. And and it's genuine because I'm really curious and want to know what it is that they're doing, because that builds some knowledge. Y'all know I keep all kinds of stuff up in here. Be like, I know somebody told me XYZ, and then I have other people who I know that it may benefit them. You know what, I talked to this lady and she said da 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 da. Maybe y'all can hook up because you're looking for X and you looking for Y. Maybe y'all can do something together. And so I usually make connections with people based on my networking as well as networking that someone has done with me. So absolutely, networking is the thing. Island Girl Forever said, what's crazy is there is such a shortage in inpatient coding. You would think they would create a support program, apprentice program for outpatient coders to transition into inpatient coding. My question is, who is they? Who is the they?
And here's the thing, and I had put in the comments that I totally agree, but that is never going to happen until, honestly, until there's a law that prohibits outsourcing. Once
Because
they
now
have to,
it's
right?
that's rampant.
Because that's their get out of jail free card. The reason why there's no training programs is because they're paying people $4 an hour across the water to play with codes. Because I see it all the time. Like, they wear me out with these ridiculous query requests. Don't even know basic guidelines. I had a situation where the person, how are you a coder and you don't know that there's an assumed relationship between osteoporosis and a fracture? Like, that's basic. Like, you automatically code it as pathological. That's a guideline. But I almost every coder that I've worked with, I've had to educate them on that and send them the guideline. That's ridiculous. Why not? I mean, if you're gonna muck it up, let somebody here muck it up.
Exactly. Exactly. That's a whole thing going on, and it's sad. It's sad that, and it's not just our profession either. Now I'm learning it's a whole bunch of professions where they're offshoring um, their positions because the labor is cheaper, but it's the quality. um, yeah, I don't know. Though to me those numbers, the math is not math, and it they have to make it make sense. And it doesn't make sense to me because if you're still having to do all this additional work, just because you got that initial piece off for $2 an hour, you still got to pay somebody else $30 an hour to clean up their mess. So
Right. But in the meantime, they've saved $26
how?
because that person on the other end is going to clean it up and make it right. They don't care how it gets done as long as it gets done. Now, it creates a burden for the secondary person because, like, and that's the other thing.
But
I don't
I
think.
mean, but how is the savings? Because you still, so what you thought you can get off clean, great for $2 an hour, it's not. Somebody still got to come back and clean up that mess and take
But
the additional hour. So what that the $2 an hour person did in 20 seconds or an hour, you got somebody who had to spend additional hours or more time
but
cleaning up the mess and reconcile it. So I don't understand how it
oh,
makes sense.
it makes perfect sense because you think got to think about from a business standpoint. They are saving money, but the burden of work is on that secondary person because you're basically doing two jobs in one. You're basically working as a second level reviewer. That's really what you're working at, but you're not being paid like a second level reviewer because that person sends something or they ask you to look up something. It could be totally jacked up. Then you have to take the time to read through reread the documentation and say no, because of this blah blah blah, this doesn't need to be coded, or because of blah blah blah, this is the primary or the principal diagnosis. Then you'll send it back to them, then they'll come back, I agree. Then they change the code and then all's well with the world because that company has saved money and that claim is going out.
No, but I'm owner. I done paid two people to do the work that's I should have paid one person $2 an hour to do. So how am I saving money in my because if I done forecast it, I done said, oh, well, if I ship all of this stuff to these people who gonna get this done, this is the expected result that I'm coming on the back end. So I shouldn't have to pay somebody else to now come in and clean up their mess. I'm paying two people
But
that math don't math it as a business owner. That don't.
but no, because you're confusing process with profit. At the end of the day, they have saved money. That's why they do it.
I guess. Okay.
I understand what you're saying because back in the day, that's how it was. I mean, because a lot of people don't. Well, most people who are new to coding, they don't understand that almost every claim gets reviewed twice in house. All they have done is that first review is just done by people that they ain't paying no money for. The second level review before it gets because and then the thing is like they don't care if they have to rebuild a case. It doesn't matter
No,
because
you're right.
you have a year to do it. So even if that person did, because claims drop now like within 3 days, 72
3 days.
hours, it's gone.
Yes.
Whether it's right, wrong, or indifferent, they'll fix it on the back end.
Right.
So if you have to
Again,
send
that's the thing. You. I mean, I guess you build into your process or profit and process the rebuilding on the back end. But what's the point of the front end if that initial $2 an hour person, if I still gotta have somebody who knows whatever to do it, especially if they messing it up and jacking it up, and they messing it up and jacking it up. I don't know. Mm. Bless all they hearts. Somebody comes in. What they say? I've seen a hospital that provides paid training for inpatient coding. Afterwards, you have to commit to working. there for 3 years. They have 5 positions and almost 1,000 applicants. Wow.
Well, I don't know where you are, Ambrose, but can you drop those names in the chat so people can find to get these hospital names and maybe just put them on their radar to look at, to look at for future reference? Because I've never seen it. That'd be helpful to somebody.
Mm-hmm. All right. Well, real quick, because we done passed the time. Look, we what I thought was gonna be a quick, easy peasy. We done talked. The talking, the tea has been spilling. um, that's and maybe that's me. Maybe I'm in
No,
the
I
minority.
I totally agree, but that's not how they think. That's not how they. All they care about is that it gets done. They don't care whether it's on the first try, the second try, and if the first try can be done at a discount, oh well, it'll get fixed because these people know what they're doing. They'll correct it, and all's well with the world.
Okay. So then this other piece of information was based on skills based hiring. So I was in uh wait, they don't tell me who wrote it. Oh, Ebony Flake wrote an article in the Essence online magazine, and she talks about skills based hiring, a game changer or barrier for Black women in healthcare. Um, so of course, all of that piqued everything I had. So I said, well, let's talk about this. So she goes on and talk about how, um, with the arrival of AI and um, the end of the pandemic and the post 2020 DEI, that's diversity, equity, and inclusion backlash. Now the future of work is looking a little different, and so they're looking at a more skill based hiring um, paradigm, if you will. Um, so this is supposedly going to, and the part about this that I was reading is because I'm trying to, me, I'm looking at health information in this, and I'm like, well, we already got skills, we already got. So this is kind of it's healthcare in general. Let's start there. Healthcare in general. Um, and so it's like putting more emphasis on the skills that you bring rather than like uh your traditional things such as education and work history. So one way, and we've talked numerous times about assessing that skill, is with those, pre-hire assessments or whatever. Um, but the thing that they were seeing, and they said all of this is good as well, and then also a lot of employers are focusing on your soft skills as well. Um, and we've too have discussed those as well. However, um, the skills based, I guess, if done appropriately and done right, helps mitigate some of the biases in hiring. So, you know, if all things being quote unquote equal, what does a skill look like for the candidates who are applying for the particular job? Um, and then, again, once you get your foot in the door, then there may be additional opportunities to advance and climb your way to wherever it is that you're trying to climb to. However, the thing was that there were still concerns about the skill based trends for Black women in healthcare because, as we know, if it's done properly, um, it can reduce and she specifically talked about gatekeeping, and again my eyes peaked once again in the article because it can kind of eliminate or close the gate, if you will, on some of these schemes. However, if it's not, then you're now the floodgates are even further wide open. um and so she gives some other challenges based in wait, I had highlighted something. So it's just saying she gives being cautious about this skill based um, hiring, because they're putting it out there as something that is of course positive, and um, allows this whole hiring game to be changed if it's truly based on your skills. But again, we all know, we've been here, um, we're working in healthcare. I mean, we're in a different dynamic of healthcare, but you can have all the skills in the world and still get caught up in the gatekeeping trap. And we kind of talked about that earlier, of ways of trying to massage that by networking and getting to know people. But just know that unfortunately, um, using skills, you have some tried and true folks who are still from the old school and the old guard, that are still at the helm of a lot of these health information um, uh, positions and departments, um, etc. And while this is kind of new and fresh, a new and fresh idea, they hold tried and true to the old guard. And that old guard is, while it can involve your skills, we know that there is some things that are contrary to that. Um, we talked about the networking and who you know, but also, well, where did you go to school? What, what, who do you know here? That type of thing. There's still bias out there. There's a lot of bias out there, and we can't not recognize that it exists. We can't put our head in the sand and be like, no, it's still there. It still exists. I mean, look around the spaces. Even if you go to, and you go to your local chapters, and you go to state, look around. Them rooms don't look like regular rooms that you may be in. Um, is there a reason for that? I'm sure there is. Do we talk about the reason for that? Not really. But just keep your head on a swivel, and know that while this is fresh and new, and this is something that's coming, that's being uh, used as a tool to hire folks based on their skill, know that there may be some things, particularly in healthcare, particularly in the healthcare field, uh, piece of the field that we're in, that may be contrary to that. So I just want to put that out there. Mr. Jesse, did you have any?
I just want to say one thing to add. I just think that the way around all of this is, and this is going to be a good plug and a segue. The way around all of this is what we talk about every week in the meeting after the meeting. The only way around this, because gatekeeping will never end. And it will take a long time for us to get in position. So the way around that is we need more people like us to create our own opportunities. Then by us creating our own opportunities, then we'll be able to reach back and bring somebody under us to get some experience to put on a resume to be able to compete for other positions. That's the only way.
That was a beautiful segue. Look at you.
Mhm.
Let's put you on a commercial. I love it. I love it. All right, y'all. Well, there you have it. Was the tea spilled today? Was the
Yep.
tea spilled today? As Mr. Jesse mentioned, we are about to transition over. We're gonna be a little late, but we're about to transition over into the meeting after the meeting. And if you want more information on becoming one of our Patreon, we open that up specifically to our Patreon members. You can check out the oh wait, I was supposed to show the thing. You can check out the link in the description box, or I think I still got this slide. Yeah. Or you can check us out here. Again, this is where it goes down. We have conversations about all things. I'm sure we're gonna spill more tea on the conversations we have today. But then we kind of walk you through. Um, so as things as you may need to pivot in our field, what are some other ways that you can pivot that may not necessarily involve having an employer? Maybe it involves you being the employer, you bringing a whole our crafty coder likes to say, bring the whole meal, bring the whole table, bring the chairs, and put the people in the seats as well. And there are a lot of opportunities around that, and we kind of talk you through what that may look like. We provide information from not only our expertise but other experts in those spaces that will help you, even if you're thinking about that, but then actually help you put some of those things into action. So yeah, I like that. We do. So with that, um, we're going to close out and thank you all for joining us at the Saturday morning tea or checking out the replay. If this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave out, don't forget to hit the thumbs up or like button. You know we need engagement. Also, check out the Coding Nurse channel on YouTube. You know it's some gems over there. You already know. My friend is a master of everything. He knows a little bit about all things, and he gonna share it. So check out um his YouTube channel. Um, so Mr. Jesse, did you have any additional closing thoughts for
Before
for
we
the
leave,
day?
I just want to say that um, Ambrose put in the chat Christiana Care, and
Ooh.
Christiana Care is in the Philadelphia metropolitan area. It's in Delaware.
Uh-huh.
So if anybody, and I don't know if they, if it's a remote position or if they have remote available, but she. So thank you, Ambrose, for putting that information into the chat so people can put that on their radar. Christiana Care, so you can go and see what their ad is, or then you can even how you can do it is that you can even pick out some words in the ad to use as keywords to find other positions that are like that. Oh, fully remote. So even better.
Mm-hmm.
So,
Even better.
Ambrose gave a gem. So yes, thank you. Thank you.
Thank you.
Thank
We appreciate that. Look,
you.
see what
Yes.
happens when we all come together and
Hmm.
spread the wealth. Now, I will say I done did a video on Christianity Care because there's some issues, not in the coding realm, but in some other things on the compliance tip. But that's neither here nor there. Go and get your skills.
There you go.
Go and get what you need to
Look,
level up
look,
on them.
let he who was without a corporate integrity agreement throw the first stone. Ah!
CIA, CIAs on the prowl. CIAs. Ooh, I love it. I love it. Oh my God. Yes. I love it. See,
I had to. That was an easy
it was
setup.
an easy
Thank
one.
you.
It was an easy
Yes.
one. You're welcome. You're welcome. So again, oh my God. This has been a great session today. Thank you for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. We'll see you later. Have a great, happy Easter, and
Yes.
all of the things that entails for you and your family. For those of us in the Patreon, we'll see you in a couple of minutes. All right.
Go.